Hi everyone, this is Dr. Ruvalcaba with a review of concepts of care for patients with cardiac problems, heart failure, valvular disease, and cardiomyopathy. These are the learning outcomes. Okay, so what is heart failure? Heart failure is a pump failure, basically. The heart is too weak to pump blood. Therefore, the amount of blood and oxygen that is getting to the heart and the organs is very little. And so when the heart and the body does not receive blood, therefore oxygen, there is a decrease in body perfusion. Heart failure is a chronic condition with periods of what we call exacerbation. Unfortunately, the exacerbations will get worse as time goes by. What causes heart failure? It can be a number of things, but any heart disease like acute coronary syndrome, anything that affects the structure or the function of the heart can lead to congested heart failure or heart failure. It can affect one side, the left side, it can affect the right side, or it can affect both. There are three types of major types of heart failure, and I'll go over these. So this is kind of what the heart looks like. It's all tuckered out, tired, can't do it anymore. So just imagine that the heart is very, very tired. All right, let's go over left-sided heart failure. Every time you think of left side heart failure, I always think about the lungs, and I always think about the major sign and symptom, which is dyspnea or difficulty breathing. Now, like I mentioned earlier, causes for heart failure is anything related to the heart, whether structure or functional. Also, long-term hypertension can also. Now, with heart failure, especially left heart failure, there is fluid accumulation, and this leads to like the dyspnea. There are two types of left side, and they're called systolic and diastolic. Systolic is when the heart contracts hard or forcefully during systole, it ejects blood into the circulation. Well, in systolic, that is not what's happening. Okay, it's not contracting, contracts weakly. Again, not being able to eject blood into the circulation. The diastolic heart failure is that the ventricles cannot relax enough, so it could fill up with blood. And so if there's not enough blood cannot be transported to the pulmonary arteries, the veins, and all that. There is a term called ejection fraction, and that's what kind of like what I mentioned earlier is how much the heart contracts in order to eject blood into the circulation, and it is measured by percentage, and it relates to cardiac output. And so when cardiac output is less or low, there is fluid backup. Now, I guess the number here that we would be very worried about is anything below 30%. I guess it also depends on the patient, but less than 30% is kind of like the number. And for those patients, they may have to have be cardioverted or have an internal cardiac defibrillator. Right-sided failure. Here are the causes for right-sided failure. The right ventricle, again, does not empty completely. Again, it's not pumping the blood to the lungs as effectively as it should. So the exchange of CO2 and oxygen is affected, and this causes fluid buildup in the surrounding tissues, which is going to cause swelling. So whenever I hear the term right-sided heart failure, I always think of swelling. I always think of edema. And it can be edema to the feet, to the ankles, to the hands, and accumulation of fluid in the abdomen, which is called ascites. High output failure is one term that I have not really heard or used in the past, but the heart is pretty much okay. It's normal, good cardiac output, but for some reason, it is causing some problems, some issues. Now, this could be related to sepsis. Maybe the person goes in with a severe um, septic infection, maybe leading to multi-organ failure, a high fever, anemia, or even a overactive um, thyroid. This one is rare, so you may not see a person who with the diagnosis of high output failure. As I mentioned earlier, heart failure is, they have a classification and they have stages, heart failure, and this is from the New York Heart Association. And so this is kind of what the physicians will based on when you have a patient come in, and they have to classify it. Um, For example, let's see, there's one here that says, okay, the one that I would worry about, not that I would worry for any of these, but remember I said that heart failure is chronic, and every exacerbation, it becomes worse and worse. So the patient really, it's not going to really get better. They can only treat these periods of exacerbation. And and so sometimes they have end stage heart failure where any treatment or all the treatments that they've tried have not helped. So this is kind of like a time where and they need to be approached for some palliative care. Also making sure that they have an advance directive and a power of attorney and all those things that patients need in order to get their affairs in order. This is another part of that classification, and it kind of shows the symptoms. Well, when the body finds itself in a predicament like heart failure or any other situation, the body tries to compensate, at least temporarily. So, two of the ways that the body tries to compensate for this lack of oxygen and perfusion and all that is done by more than two systems or areas. One being hormones, where epi and epinephrine are released. And what happens is that these hormones, the epi and norepi, will cause the heart to pump faster and even more forceful, because that's going to help the heart increase the amount of blood that's being pumped. Okay, pumped out, and that is your cardiac output. The second body system is the kidneys. It increases the amount of sodium and water instead of excreting it through urine. So therefore, when your body has more fluid, it increases the volume in the blood, and it helps maintain blood pressure. Also, myocardial hypertrophy, myocardial is the heart muscle, hypertrophy is enlargement. So enlargement of the muscular walls of the ventricles will allow the heart to maintain the amount of blood that it pumps out. So again, there's these compensatory mechanisms temporarily that the body uses in order to get them through a certain acute stage. Okay, heart failure. I did mention earlier about how any type of condition of the heart can cause heart failure. Others are systemic hypertension, somebody who's had an MI. So those are some of the ways that are causes of heart failure. About 6.5 million people in the US have heart failure, and it is the most common reason for readmission for those folks that are 65 and older. And it's more common in African American individuals under the age of 50. All right, so when you're admitting a patient with heart failure, there's a lot of information that you need to really obtain. And so one obviously is a history, and you guys know this from health assessment. You take a history, and in the history you look at the history of present illness and past medical history and all those things. So when you have somebody with heart failure, you want to get a thorough history. There's a lot of questions that you want to ask the patient. History of any heart conditions. How is their tolerance to activity, and how are they doing with breathing, sleeping, and peeing, if you will. So you want to ask the patient, for example, are you having chest pain? Are you having palpitations? Are you having a cough? If you do, is it productive? If it's productive, how is it thick, thin, and what color it is? You want to ask them, do they have shortness of breath when performing activities of daily living? You want to ask them, do you have shortness of breath? Do you have difficulties breathing? Do you have difficulty? Is it worse when you lay down? How many pillows do you sleep with? Do you sleep in the recliner? And do you have difficulty at night? And that's called paroxysmal nocturnal dyspnea. And so, the soreness of breath, the dyspnea, asking about the pillows, that, kind of helps us know whether is this right side or left-sided. You want to ask him about swelling, edema. Are your shoes too tight? Have you gained some weight in the last week? And if so, how much? Do you wake up frequently at night to go urinate? You also want to ask him about their diet. And I talked about the salt intake. Do they still, are they drinking a lot of fluids? So again, a lot of investigating that nurses need to do to try to get to the bottom of, what's going on with the patient. And this helps with the diagnosis as well. Okay, so for left-sided failure, again, I always think of left side lungs, because you're going to see all of anything that's respiratory related. You may see this with left side heart failure. I talked about the dyspnea, the difficulty breathing where they're laying down. That's called orthopnea. They're going to be tired. They're going to be weak. They're not going to be able to bathe themselves, to cook, to even walk, to turn off the TV. I mean, that's how fatigued and tired they can get. They may become restless. Maybe they'll have some periods of confusion. You wanted to observe, are they using accessory breathing muscles? Do they have nasal flaring? Are they retracting? You want to listen to their lungs. Do they have crackles or rhonchi? And one of the things that we have to be cognizant about with heart failure is a complication, which is pulmonary edema, which is collection of fluid in the lungs. And this is an emergency, and so the patient will be tachypnic. They're not going to look good. They're going to be pale or maybe ashy color. They may be lethargic or confused. And one of the tell signs is the pink frothy sputum. So how is this going to be treated? With diuretics to kind of remove the fluid, morphine, and nitroglycerin. So right side failure. So again, right side failure affects the rest of the body, and I kind of relate it to edema or swelling. And you can see that when they have the jugular vein that is distended, maybe some fluid accumulation in the abdomen, ascites, dependent edema, maybe their liver has enlarged. Um, but weight is the most reliable uh, indicator of whether the patient is or gaining fluid, gaining weight or losing weight, and that will tell us about um, fluid edema. Let's see what else. They'll have increased heart rate, increased blood pressure, increased respiratory rate. They become confused. So again, right-sided failure, edema, swelling in the rest of the body. These folks you want to, with heart failure in general, not just right or left, is that you want to assess for their, how they're doing mood-wise. Are they anxious or are they depressed? How are they coping with all of this? Because of the nature of this disease. So remember that not only are assessing for physical signs and information, but we're also looking at their mental status as well. Here are some of these are more diagnostics as well as labs and radiology or imaging that they'll do to kind of evaluate how the patient's doing. And so obviously for blood work, they're going to do like a complete metabolic panel. That's your sodium, potassium, and H&H is very important. The BNP, which is a B-type natriuretic peptide, it's a protein that forms inside of the heart chambers, and when that protein builds up, it applies more pressure to the heart and can lead to heart failure. Urinalysis, ABGs, very important. ABGs. As far as imaging, they can do a chest X-ray to start out with. They can do an echocardiogram where they're looking at the heart muscle. They can do radionucleotide studies where they use radioactive materials to diagnose and stage the disease. And finally, remember I talked about the ejection fracture. Well, the MUGA scan is performed because it measures the percentage of the ejection fracture. These hemodynamic monitoring, that's more for the ICU. You'll learn more about that in your other semester and your advanced med surg. So here are the priorities. The cues is your signs and symptoms, and we've talked about that. We talked about which ones are more prevalent for right side, which ones are more prevalent for left side. And so this is what our care is going to be focused on. This is how, again, what we want to accomplish, making sure that the patient gets more perfusion, there is more gas exchange, and hopefully they won't get pulmonary edema. All right, so the care for the patient with congested heart failure, there's lots of things that you can do for your patient. Obviously, you're going to be assessing them frequently, probably every 4 hours. Obviously, in tele or in the ICU, it's probably a little bit more. Vital signs, that's very important, especially respiratory rate, not just the rate, but the quality and the rhythm. Um, Obviously, auscultating breath sounds. If the patient is having the difficulty with breathing, you want to make sure that you elevate their head of the bed, high Fowlers, help them turn and reposition every couple of hours. If they're on oxygen, you want to make sure that you are checking the sats and maintaining the oxygen for a O2 sat of 90 or greater. But check your parameters and check your physician's orders because they may have different parameters. You're also going to be administering meds, and those are your ACE inhibitors, your diuretics, your beta blockers. And so, as I mentioned earlier, and I want to emphasize, as nurses, it's important, and now that you're taking Pathopharm, know what the med does. Administer as prescribed, monitor the patient for therapeutic effects. Is it working? Is it not working? Monitor for side effects and adverse reactions. If the patient suction as needed, assess the sputum, ABGs are important. You want to make sure that they're weighted daily, same scale, same amount of clothes, same time. If they're on a fluid restriction, you have to make sure that whatever total has to be divided between the meals and what you give them for what's left that you can give them for medications, things like that. And that also sometimes includes your IV fluids as well. Make sure you're taking strict INO. Again, with these patients, they are susceptible to infections, so make sure you're doing your hand washing, maintaining a septic technique, using the appropriate PPE. And sometimes the last treatment that they could try on a patient with heart failure is a heart transplant. So. All right, so interprofessional collaboration. Nurses don't work alone. There's a group of people that we work with and we collaborate and we check things with. And so obviously you have the physician and there's the nurse and obviously your CNAs and the respiratory therapists, big time. They should be your best buddy. Your social worker, case manager, did I say doctor, and maybe specialist like a cardiologist, occupational therapy. But again, that does not stop in the once they're discharged. Once they're discharged, we got to look at home management and education and what are the resources out there for for the patient. The patient needs to have detailed discharge instructions. I like the fact that somebody, when I asked, they said, well, the family member, that's very, very important because there needs to be somebody else that is listening to these instructions so they can be enforced. Because the patient is very sick and they may not remember half of the things that you are telling them on the way out. So detailed discharge instructions, which includes, diet, daily weights, meds, fluid intake. Also very important is preventative immunizations like the pneumonia vaccine, the flu vaccine. And very important is when to call their doctor or go to the emergency room. Again, advance directives so that the patient can lay out their wishes, and they can assign also a power of attorney, somebody who will act as their advocate. I talked about palliative care, and then maybe towards the end, hospice. Oh, another thing um, that they need to be the patient needs to be educated is smoking cessation. One thing though, whenever you work in a hospital and you have a patient that comes in with a specific disease process, MI, heart failure, there's going to be a order set. Okay, and in that order set is going to give you all the information about the orders and about the things that the patient needs to be educated about, and what are some preventative measures that we have to take or they have to take in order to maintain. Another thing that's very important is that you want to make sure that family members know how to perform CPR. Okay, and so as per the nursing process, you want to evaluate, did all the things that you perform as nurses, the medications, maintaining the head of the bed elevated, did that help? Okay, because otherwise, if maybe some things did help, maybe some others didn't, and so then things need to be reevaluated. Okay, the next topic, disease process, is valvular heart disease. And what this is, that there's a problem or disease process related to any of the four heart valves. And we're talking about your tricuspid, your pulmonic, your mitral, and your aortic. And we have mitral valve prolapse, we have mitral valve stenosis, mitral valve regurgitation, aortic stenosis, aortic regurgitation. So there are differences. It means the same thing when we talk about stenosis and when we talk about regurgitation. So with valvular heart disease, there is an abnormality that interferes with the unidirectional flow, meaning that the blood should be going one way in the blood circulation. Not, we don't want anything backing up. It's what we call a unidirectional blood flow. More than one valve can be damaged. Sometimes your valve disease may be congenital or may be acquired. Valves to the left are more likely to be affected because of the increased pressure. So let's define stenosis and regurgitation. Stenosis is narrowing of the opening of the valve, which impedes the blood from flowing freely forward. Regurgitation, also known as insufficiency, it's when the valves don't close properly and there's backflow of blood. So let's look at these individually. But it's the same principle if you have stenosis, if you have regurgitation. And so here I have a little visual. So you kind of get an idea when we talk about stenosis and when we talk about regurgitation. Okay, so mitral valve stenosis is caused by rheumatic fever. Usually that's what they find that is the cause. With mitral valve stenosis, the people can go a long time without showing any type of symptoms, or maybe some mild symptoms that does not ring a bell to them or doesn't seem to be an issue. With mitral stenosis, there can be some pulmonary congestion and right-sided heart failure. Again, remember, heart failure can be the result of multiple disease process happening to the heart, and one of them being problems with the valve. So with pulmonary congestion and this right-sided failure, the leaflets, those are the little, how can I say, little leaves that open and close, okay, to the valve. Sometimes they may become kind of hard, stiff, and it narrows the opening, and then it prevents the blood flow to the left atrium and the left ventricle. Mitral valve regurgitation is when there has been the valve, for whatever reason, and it can be from a disease process. The valve can become hardened, maybe some calcification, maybe there's a lot of scar tissue and fiber that prevents the valve from closing during systole. And that results from to backflow to the left atrium with the left atrium contracts. So again, it progresses slowly. Patient may not have any symptoms for a while. And these are some of the symptoms, as you can see here stated. Mitral valve prolapse, the little leaflets, they become enlarged, and instead of closing, they kind of bulge in an upward position. That's kind of what prolapse means. It bulges upward. There may be a family tendency or a family history. Again, people may not have symptoms. Some may report maybe some chest pain. Maybe, they can't run, marathon like they used to. They have dizziness. And then on assessment, if we're listening to heart sounds, we may be able to pick up a murmur. They may have normal heart rate and normal blood pressure. As far as diagnostics for any of these mitral valve, any of the valves, the four valves, will include like an echocardiogram. They can do a cardiac MRI. They can do a chest X-ray. They can even do a cardiac cath. So the treatment for any of is either repair or replacement. Especially if signs and symptoms become severe. These are the folks that, any of these folks, they're going to be on a monitor, and you may be the one that's going to connect the leads on and taking care of the patient, and so the tech is going to tell you whether the patient is having dysrhythmias or not. I hear some conflicting information because with the mitral valve prolapse, they used to tell a patient that they needed to take antibiotics before any type of dental procedure or dental work, but I read that as of late, it's no longer required for mitral valve prolapse. Okay, aortic stenosis, it's the aortic valve, and for some reason there's a narrowing. And it obstructs the left ventricle, results in the ventricle area becoming enlarged. Your cardiac output cannot adjust to the needs of the body because it's not able to pump out enough blood. Right-sided failure can be a complication of aortic stenosis. When the surface area of the valve is 1 centimeter less, surgery is indicated, meaning it's barely open. Again, the cues for any of these is dyspnea. They may have fatigue, syncope. They may have complaints of angina. And again, you can probably hear a murmur. Aortic regurgitation or insufficiency. The valve leaflets do not close properly during diastole. Again, blood flow from the aorta back to the left ventricle during diastole. And that kind of leads to, again, as I mentioned earlier, for aortic stenosis, the ventricles become excessively large, or they hypertrophy. Again, with many of these, they can be asymptomatic. There's some of the signs and symptoms. They may have a bounding pulse. Aortic regurgitation may come from conditions such as endocarditis, hypertension, Marfan syndrome. Like I said, some of this may start developing slowly over the years. One thing too that's very important when you're doing a history on a patient, and I know in any history, you're going to be asking them about the use of drugs, IV drugs, because if this aortic regurgitation is related or is the result of infective endocarditis, we always want to ask our patients the IV drug abuse, because we see that a lot. You want to get a family history, IV drug abuse. I always said that. As far as nursing, again, vital signs, inspecting for edema. You want to palpate and auscultate the heart and the lung sounds. You want to palpate pedal pulses. And so the treatment is going to depend on which valve is being affected. And some of it can be medications like your diuretics, beta blockers, digoxin, nitrates, calcium channel blockers, maybe some anticoagulants to prevent clotting. With aortic regurgitation, they are suggesting antibiotics before dental work. You want to make sure that they have a patent IV for medications and fluids. They are at risk for clotting, so you want to assess the patient or be on the alert for any signs and symptoms of deep vein thrombosis and pulmonary embolism. And most importantly, you want your patients to rest. Again, diagnostics, EKG, chest X-ray, echocardiogram. Let's see, regurgitation. We got some more stuff here. Non-surgical, I talked about medications. Surgical management. We can talk about heart valve replacement or repair. And as far as if they're going to do a replacement, heart valve replacement, they are two types. There are mechanical valve. Those are durable, they're stronger, they last for the patient's life. The caveat is that they have to be on blood thinners for the rest of their life. The other one type of valves is what we call a tissue valve, and it's created or is from animals. Donor animal valves like the pig, porcine, or the cow, vulvi. And these valves, particular valves, they last about 10 to 20 years. So for if your patient is going for a valve replacement, it can be either done in outpatient or it can either be done inpatient, depending on whether they came in with an acute episode. And so pre-op, the recommendation is that if this is kind of like not in an acute episode, but they know that it needs to be taken care of, for pre-op, they'll need some dental exam. If they're on anticoagulants, they need to be off of it for 72 hours at least, because it will enhance bleeding if they don't. As far as post-op, you want to treat the pain, you want to check the incision. You want to make sure that you do any intervention that will prevent infection, and observes for signs and symptoms of heart failure. Like I mentioned earlier, for those that receive mechanical valves, they'll be on anticoagulants forever. And with a patient that's on antibiotics, there's some things that they need to do. They need to get some blood work and to test the INR, which needs to be between 3 and 4 seconds, and then teaching about watching for bleeding and what you should do if you find that you're bleeding. Who do you call? All those things. And you can see this is a mechanical. This is what is considered mechanical valve. Very interesting. All right, and then in this one, these are the tissue valves from animal donated valves, pigs and cows, or porcine and bovine. And again, uh, every time you have a patient that's going home, you want to make sure that they have what they need to manage at home, home care. And then home care can evaluate what other needs they may have. Um, you know, the education that we need to give our patients. And it's important, very important, that we ask them to teach us back so that we can document that they understand or they don't understand and they need reinforcement. So you want to teach them about the disease process, what to look for in terms of heart failure. Make sure that they know what meds they're taking and what to look for and when to call the doctor. Prophylactic use of antibiotics, a plan of activity and rest, incision check, and there may be some issues with altered self-image. Okay, so we have the last condition is cardiomyopathy, and this is a condition of the heart muscle. There are different types of cardiomyopathy. They have the dilated cardiomyopathy, hypertrophic, and restrictive cardiomyopathy. I wanted to go over the different types. Excuse me. So the first one is dilated cardiomyopathy. This one is a common type. It usually affects those younger than 50. What's happening is that the ventricles are dilated and they're also thickened. They have thick walls. Causes can be anything from alcohol misuse, cocaine, severe infection or inflammation, a result of chemotherapy, coronary artery disease, and even poor nutrition. The cues that you're going to be seeing are dyspnea on exertion, activity intolerance, a lot of fatigue, maybe some jugular vein distension, and swelling of the arms, feet, and abdomen. This can definitely lead to heart valve problems, arrhythmias, and issues with increased clotting. The treatment is medication that's going to control heart rhythm, decrease the blood pressure, prevent clots, and get rid of the fluid. As far as surgical pacemaker, implantable cardioverter defibrillation, the LVAD, which is a device that helps ventricles pump blood to the rest of the body. That's called the left ventricular assist device. The second type of cardiomyopathy is the hypertrophic cardiomyopathy. Now this one is one that it's kind of interesting because we have seen this, and I'll tell you why. Hypertrophic cardiomyopathy is asymmetrical ventricle hypertrophy, thickened walls. This can be genetic. Okay, there can be some abnormal genes of the heart. About 1 in 500 people, especially young people, will have HCM. This one can cause sudden death of young people and athletes. And we have seen, in sports where we've had some athletes die after a game, and then it's been found upon autopsy that they had this condition. The really interesting thing about this is that the person is asymptomatic until maybe late adolescent and early adulthood. Signs and symptoms or cues are chest pain, dyspnea on exertion, angina, syncope. They may have a murmur when you are listening to heart sounds. And if they're on the telly, EKG, they may have some ventricular dysrhythmias. Again, diagnosis is echocardiogram, a stress test, CAT scan, cardiac cath, and even a transesophageal echocardiogram where they go through the mouth to the esophagus. As far as nursing, you want to obtain a good history, especially a family history. You want to know about what's some of their habits. As far as treatment, lifestyle changes, teaching about to exercise, normal exercising, diet, maintaining a normal weight, getting adequate sleep, no smoking, medications, beta blockers, calcium channel blockers, diuretics. These folks may end up, if they don't die, with an ICD, pacemaker. They may have something called cardiac resynchronization, which coordinates contraction, helps coordinate the contraction between the right and left ventricle. And if that fails, heart transplant. The last one is restrictive cardiomyopathy, and this is the rarest of the cardiomyopathies. There's a lot of buildup of scar tissue in the ventricles. The ventricles become stiff. And so because of all this buildup and stiff ventricles, the ventricles can't relax and fill with blood. And then the atrium becomes enlarged. This can lead to heart failure, arrhythmias, stroke, deep vein thrombosis. There's multiple causes. It can be a increase of iron in the body, or a condition called hemochromatosis sarcoidosis, which is a severe inflammation of the organs, or amyloidosis, which is an abnormal buildup of protein in the body or in the heart. Cues similar to heart failure, especially with the fluid buildup, the dyspnea, the swelling, activity intolerance. This condition has a poor prognosis. It can't be cured. There is no specific treatment other than treating the symptoms, providing meds like diuretics, corticosteroids, beta blockers, calcium channel blockers to treat the irregularities. The last ditch would probably be a heart transplant. And usually with a heart transplant, they will go to the intensive care unit. They will also have complaints of chest pain, dizziness, fatigue, similar to the heart failure. Diagnosis from echo, chest x-ray, CAT scan. So those are the 3 of the types of cardiomyopathy. And this is kind of like, in general, cardiomyopathy. Again, looking at, what are the signs and symptoms that we can recognize, whether it's functional or whether it's structural. They can look at, on x-ray, they can see if the ventricles are dilated. As far as diagnostics, again, echocardiogram, cardiac cath, thallium scanning, and the treatment, as I mentioned, drug therapy, which would include diuretics, vasodilators, beta blockers, antiarrhythmias. They may have to, like I said, get an implantable cardiac defibrillator. Okay, I just mentioned those.